this is a study on abiraterone being given with androgen deprivation therapy for patients with metastatic, hormone-naive metastatic prostate cancer. The background to this is that the concept is that by adding abiraterone to androgen deprivation therapy or castration therapy, that you would have a greater effect, prevent the emergence of resistance, and improve patients' overall survival. And indeed, that's what we've seen.
Okay. And then if you could just outline the main findings with the primary outcome as well as some of the secondary outcomes.
Right.
Because they were quite interesting.
Yes, that's right. So the trial was involved randomizing 1,200 patients to either androgen deprivation therapy with abiraterone and prednisone versus androgen deprivation therapy and placebo. It had co-primary endpoints of overall survival and radiographic progression-free survival. This was the first interim analysis and ends up being the last analysis because the results were so positive. The hazard ratio for overall survival was 0.62, meaning that there's a 38% reduction in the risk of death. And the hazard ratio for radiographic progression-free survival was less than 0.50, so meaning that there was a better than 50% improvement in the delay to radiographic progression-free survival. So these are pretty remarkable outcomes for this patient population.
Did you look at any other outcomes?
Yes, there was a host of secondary outcomes, including time to pain progression, which was also in favor of combination therapy, time to next treatment for prostate cancer, time to PSA progression. And we've also looked at health-related quality of life and patient-reported outcomes. That was not reported at this meeting, but will be reported at a subsequent meeting.
What about subgroup analysis? Are there any patients who may or may not benefit more or less, as the case may be?
Treatment was in favor for all subgroups that were looked at, whether it was ECOG performance status, presence of visceral metastases. All patient groups benefited from therapy.
And the side effect profile, the toxicity profile?
Abiraterone is well known, and we've been using it for many years in a later stage metastatic castration-resistant prostate cancer. So it does have side effects in terms of increasing mineralocorticoids, which we offset by giving prednisone, which decreases ACTH, decreases mineralocorticoid levels. But we still do see some hypermineralocorticoid side effects such as hypokalemia and hypertension, but these are easily managed and evaluated. We also do see some liver enzyme test abnormalities. About 5% of patients get grade 3 or higher liver enzyme tests, and this necessitates stopping the abiraterone and reducing the dose. But again, easily managed, usually occurs within the first few months.
So one of the things we're wondering about is, so we heard in the presentation just now about how it's going, it's going to be or should be the new standard of care.
Yes.
It's quite different in terms of its administration to docetaxel.
Correct.
So how do you go about counseling your patients over this you have to take this long-term therapy versus a short, sharp, quick, essentially?
Short, sharp, and quick. Well, I think most patients, given the choice between a long-term, well-tolerated oral therapy versus an intravenous toxic chemotherapy, will choose the long-term oral therapy. In fact, in my jurisdiction in Canada, where I treat patients, probably 60% or 70% of patients will never get chemotherapy because they're just comorbid status, advanced age, or they just decline chemotherapy. So I think we have to recognize that chemotherapy doesn't apply to everybody, while abiraterone is a very safe drug to be used, that can be used in most patients.
And then we also had the results of the STAMPEDE trial.
Yes.
How do you kind of put it all in context in terms of the bigger picture? If you are able
So I think this is where some of the ongoing debate is going to happen. LATITUDE enrolled patients that were relatively homogeneous in the sense that they all had to have high-risk features, so they were a poor prognosis group of patients, while STAMPEDE accrued patients that were much more heterogeneous, anywhere from patients with just locally advanced disease to node-positive disease to high-volume, high-risk metastatic disease. And so it's a very much more heterogeneous patient population. Despite that, STAMPEDE still showed a similar benefit to LATITUDE, suggesting that patients at all, whatever stage of their disease is at, if they're receiving androgen deprivation therapy, adding abiraterone can help them. However, the survival advantage in STAMPEDE was almost all driven by the patients with metastatic disease. And so there's very few events in the patients without metastatic disease, and those patients, you're committing them to long-term treatment, and there the cost-benefit ratio may not be in favor of that. So I think there's going to be ongoing debates about this, and there'll be ongoing analyses to see what is the benefit in those patients.
So what are the next steps?
What are the next steps? Well, I think one of the unanswered questions is, well, what about adding docetaxel, abiraterone, and androgen deprivation therapy together? So we do not have that information. We will not know that. There is an ongoing trial that will be looking at that will report out sometime in the future. There's also several trials looking at the next generation AR antagonists, such as enzalutamide and apalutamide, in this patient group. And those studies allow the use of docetaxel. So I think we're going to see more, we'll see these trials read out in the next few years about not only the next generation AR antagonists, but also maybe the benefit of chemotherapy within that.
And finally, is there anything else you'd like to add?
I think these results are remarkable. I think it is a new standard, and I think in the time being it will replace chemotherapy.